Hello, everybody. My name is Kyle Klarich. I'm a consultant in the cardiovascular medicine department at Mayo Clinic in Rochester, Minnesota. And we are coming to you with interviews with the experts. And today our topic is perioperative cardiovascular management for non-cardiovascular surgery. And I'm privileged to be accompanied today by our expert, Dr. Michael Cullen. Hi, Mike.
Hey, how you doing, Kyle? Thank you.
Oh, yeah, you're very welcome. Thank you for being here. Dr. Cullen is an associate professor of medicine and a consultant in the Department of Cardiovascular Medicine at Mayo Clinic in Rochester, Minnesota. His clinical work actually focuses quite broadly on echocardiography and general cardiology. He serves as the associate program director for our cardiovascular disease fellowship program and directs the Mayo Clinic cardiovascular board review course, which is widely appreciated both in person and virtually. His audience and has been multiple cardiologists and multiple CME meetings across national and international venues. He has done academic research in both perioperative cardiovascular care, familial hypercholesterolemia, infective endocarditis, and cardiovascular education. So I think he's well prepared to discuss with us today how the management of cardiovascular patients undergoing non-cardiovascular surgery can be optimized. Mike, thanks again for being here.
No, thank you, Kyle. I appreciate it. This is always a tough topic, and some areas, that patient comes for a quote perioperative exam, or PAMI as we call it here at Mayo, and people are always raises some questions, and these patients always show up at 4 p.m. on a Friday. So hopefully we can help answer some of those questions.
Exactly. Well, how do you think clinicians should initially approach the assessment of a patient prior to a non-cardiac surgery?
Right. The guidelines will say that we should take a very stepwise approach and just ask a few basic questions. And so if you're seeing a patient in the hospital or in the emergency room and they need emergent surgery, you just send them to the operating room. You're done. If they're having an acute cardiac event, like an acute coronary syndrome, acute heart failure decompensation, acute unstable arrhythmia, you have to treat that. Usually, particularly for outpatients we're seeing, or even for inpatients, the answer to those first two questions, they don't need emergent surgery and they're not having an acute cardiac event. So then you need to look at the risk. And you look at two aspects of risk. You look at their clinical risk and you look at their surgical risk. In terms of clinical risk, you can use an old estimator like the RCRI criteria that looks at things like diabetes, coronary disease, heart failure, things like that. There's six criteria. And if they have multiple of those risk factors, they're considered elevated risk. That's a quick and dirty way to do it. We have some more sophisticated calculators available, like the NSQIP calculator that you can go online and Google pretty easily, and you can plug a bunch of different variables in. So the clinical risk is one aspect of the risk. And what the guidelines suggest and what the new guidelines actually highlight is that part of your clinical risk should really assess for frailty. So if a patient is weak, if they're not very mobile, if they've lost weight, if they complain of fatigue, they're tired all of the time, they sort of look frail, that's obviously a marker of higher cardiovascular risk. Maybe you start to have some of those goals of care discussions sooner. Maybe you start to question if the surgery is necessary. Um, and some patients may actually benefit from like what we call prehabilitation, where they start to exercise, start to try to improve their functional status, work with maybe physical and occupational therapy before the operation, if you have some time to try to get them in better shape to get them through the operation. So that's sort of how you assess a patient's clinical risk. In terms of the surgical risk, the really high risk operations to think about are thoracic surgery, vascular surgery, solid organ transplants. So if a patient is having one of those, their surgical risk um, is going to be quite a bit higher than patients who are maybe having an orthopedic operation or breast operations, more superficial operations like that. So even abdominal operations are not considered as high risk as like a vascular or thoracic surgery in terms of the risk of cardiovascular complications. So your third question is, what's the patient's clinical and surgical risk? If the risk is low, which the guidelines will say combined clinical surgical risk less than 1%, then you're done. You send them to the operating room. If they're not low risk, and most of the patients that we're going to be seeing are not low risk, then you have to assess their functional status. And in terms of functional status, the same questions still apply that we've always done. Can the patient climb a few flights of stairs? Can they walk a few blocks on the level ground? Can they perform some light housework? If they can do those activities, they can probably do at least 4 minutes of activity. If not, or if you just can't assess it because of some orthopedic limitation or other functional limitation, then you have to ask, do I need to do anything else? And if I do anything else, is it going to change what we do? Is it going to change where we have the surgery, whether or not we do the surgery, what medications I give around the time of surgery? So that's when you start to think about biomarkers and stress testing and additional tests and things like that.
That's a lot of information. Let's break it down a little bit. So I think what I heard you say is there are clinical risk calculators.
Mhm.
Repeat what those two are, and if are they ones that would be available for someone to say, you said, yeah, I think you mentioned you could download them onto your computer, but maybe also in this day and age, having them on your handheld device,
Yeah.
iPad or iPhone or Android would be very helpful, and you could just punch in the
Yeah.
six things that you need to know for the more simple of the two.
Well, yeah. If you need a quick and dirty estimator of risk, the RCRI criteria is tried and true. It's been around for over 25 years, initially published in 1999. Looks at whether or not the patient has ischemic heart disease, history of heart failure, creatinine over 2, prior stroke or TIA, insulin-dependent diabetes mellitus. So those 5 criteria, if the patient has 2 or more, they're considered elevated risk. Now, that obviously doesn't incorporate a number of other comorbid conditions like hypertension, smoking, hyperlipidemia, diabetes that doesn't require insulin, those type of things. So you have to take that into your assessment. But the RCRI is a quick and dirty way to do this. And then um, certainly, as I mentioned, more sophisticated calculators are available. The NSQIP calculator, you can find apps to do that. You can find websites. It's easily Googleable. Even some institutions probably incorporate this into their electronic medical record. And there are a number of different calculators available, but those are probably the 2 most popular.
And you mentioned one's more sophisticated than the others. In your own practice, which one do you tend to reach for, and when do you decide to maybe go to the more sophisticated?
Yeah, I think the real determination you want to make is this patient low risk or not? Um, and I would argue that most of the patients that we're seeing from a cardiovascular perspective are not going to be low risk. Otherwise, they wouldn't need to be coming to us. They probably have at least a few of the predictors in the RCRI criteria. So you're already sort of down that pathway that the guidelines recommend in terms of determining whether or not you need to think about additional testing. You need to assess their functional status and then determine whether or not they need additional testing.
If you're lucky enough and you have one of these patients, the risk is less than 1%, then you can okay them for surgery. But as you
Yes, absolutely, yes.
Yeah, and then you just alluded to the fact that most of them are going to be a bit more than 1%
Mhm.
risk. And that's the clinical risk factors. And if that's the case, then you're going to look for their functional, either self-reported, or you may need to go to some testing to get that.
Right, exactly. So, in terms of functional assessment, the Duke Activity Status Index is a tried and true way of assessing a patient's functional status. But you can do this with a few basic questions like whether or not the patient can climb 2 flights of stairs, walk a few blocks on the level ground, rake leaves, push a lawnmower, do light housework. Because the big determination, still, and this hasn't really changed over the years, is whether or not the patient can get to 4 minutes.
Okay.
And those activities that I mentioned are still sort of the cutoff for what we consider 4 minutes. If you need to, you could put them on a treadmill and sort of assess their functional status with more detail, but that's often not necessary. But if they can't do 4 minutes, or for one reason or another, either they just don't because they're limited, or they have an orthopedic impairment or something like that that keeps them. Maybe they used to up until about 6 months ago, but they're having their hip replaced, and because they're having their hip is under a lot of pain, they just can't do that. Um, then you have to sort of put them into the less than 4 minutes or unknown category. And that's when you say, well, do I need to get biomarkers? Do I need to get a stress test? Do I need to get anything else? And this is really where some of the guidelines start to differ. So the American guidelines, which were just released by the ACC, um, and AHA and a number of other cardiovascular societies in 2024 had sort of hemmed and hawed around the whole notion of biomarkers in the previous version of the guidelines from 2014. In the current version of the guidelines, they say that if you have a patient with known cardiac disease, which is pretty much everyone that we're going to be seeing, and they don't specify what known cardiac disease is, so coronary disease, valve disease, you name it, heart failure. If they have known cardiac disease or age over 65 or any cardiovascular symptoms, which again is pretty much everyone that we see, they have a 2A indication for checking a preoperative NT-proBNP and a 2B indication for checking pre and post-op troponin. Now, the European guidelines take a little bit of a different tact, and they were released in 2022. And what they suggest is that if you have a patient, intermediate or high risk patient undergoing a high risk surgery, they actually give a class 1 recommendation that troponin pre-op and 1 to 2 days post-op. And they give also a 2A indication to measuring natriuretic peptides like an NT-proBNP. What do I actually do in my practice? I don't tend to use these a ton unless the diagnosis is uncertain, particularly for the natriuretic peptides, or if they have known heart failure, you can use it for prognostic purposes. But again, that's not something you'd necessarily do for preoperative purposes anyway. You do it for management of their heart failure, which is perfectly appropriate. The troponin, I'm less excited about. The American guidelines are less excited about that than the European guidelines. I think if we start chasing troponins, we get into a lot of places that we may not necessarily want to go. If the patient is really, really high risk and you're really concerned and like they're undergoing a major vascular surgery, you could get a troponin not for the purposes of like ruling out an ACS like we do in the ER, but for the purposes of establishing a baseline in case they get a troponin check post-op and you're not involved. Then it just helps the people who are going to be taking care of that patient in the hospital understand the significance of that post-op troponin. That would be the goal for it.
Perfectly. I love the way you said that, if you have concern that someone has an elevated troponin kind of at baseline, and we do see these people, there are people out there, and I certainly see a lot of them in my cardiomyopathy practice that have either mild, maybe even a little higher elevations at baseline of sometimes NT-proBNP, but also troponin. And then knowing what those are so that you can kind of follow that post-operatively, especially if there's some question about their monitoring or their EKGs or anything else that you can kind of say, well, we do know this patient has elevated troponin. So that's a really, really good point.
Yeah, and I think that's kind of the tact that the guidelines will take. Like I said, the European guidelines come out much more strongly in favor of that, but we really haven't seen the data to suggest that measuring we know that pre-op troponin predicts post-op troponin, and pre-op natriuretic peptide predicts post-op natriuretic peptide, but I haven't seen big trials to suggest that if you check it beforehand, it's going to actually change how the patient does afterwards. The other test that I think is useful to mention is stress testing, right? And this has been the age-old question: do I get a preoperative stress test? The short answer is no. You do not need a preoperative stress test to quote just to get the patient through the surgery. And our guidelines have come out pretty strongly and actually given a class 3 recommendation to say that there is no benefit to stress testing if you have either a low risk patient or a functional capacity over 4 METs, or they're undergoing a low risk surgery. They say that maybe you could consider stress testing if you have all of the following 3. If you have a high risk patient, their functional capacity is less than 4 METs or unknown, and they're undergoing an elevated risk surgery. But then you have to ask yourself, what are you going to do with the results? Right? Because really what you want to know is if you're going to stress someone now, obviously, if they're symptomatic and you would get a stress test independent of the surgery, work up the symptoms, certainly. But if they're asymptomatic, you have to ask yourself what you're looking for and what are you going to do about it? And and then this gets into the questions about whether or not we revascularize asymptomatic people. So you're really looking for left main proximal LAD multivessel disease. right? So if the ventricle falls apart when you stress the patient, you cath them, they've got left main proximal LAD multivessel disease. Then you have to think about does revascularization here. This is a patient I probably want to think about revascularizing anyway, even if they're asymptomatic, independent of the non-cardiac surgery. And then you have to think, okay, depending on then you have to factor in all sorts of factors. What's the urgency of the surgery? How do I want to revascularize them? Do I think about PCI? Do I think about coronary, coronary artery bypass grafting? And there's all sorts of nuances that come into play in terms of their ability to tolerate antiplatelet therapy, their ability to hold antiplatelet therapy, their ability to get through an open sternotomy and cardiovascular bypass. So to go into the specific nuances there, we could spend all day talking
Right.
about that.
Right. I
But
think,
those are some of the important considerations before you just
yeah,
get a
I think you
preoperative
summarized
stress
it.
test.
Exactly. I think you summarized it very well that, that once you start having a patient that's really a cardiovascular patient, and that's discovered because of whatever testing we did, then you have to decide whether the surgery needs to be done. We already said urgent surgery, we just keep going. We don't even test. But if it's
Right.
semi-urgent or depending how significant the underlying reason for surgery is, it becomes a little bit nuanced. But I love using those risk calculators that you mentioned. I think calculating the risk of the surgery. Is there a specific calculator for that you use?
Well, the NSQIP
Is
calculator will incorporates the surgical risk as well. But the big ones, like I said, quick and dirty, the ones that data shows it can be 5% or higher, it's going to be vascular surgery, thoracic surgery, and solid organ transplants. Those are the quick and dirty ones to remember for the maybe the phone calls or things like that that you might get. And then you're thinking like neurosurgery, abdominal surgery, big skin or burn operations, big ENT operations, GU operations, ortho operations. Those are sort of intermediate risk. And then when you think about like endocrine or breast or GYN or ophthalmologic, eye procedures, those are going to be typically
lower.
low risk. Yeah.
Perfect. It's still complicated even after all these years, but I think you did a nice job of giving us some tools that we can use for, judging the risk and then when to go down the stress
Mhm.
pathway. So thank you for that. I think maybe we'll just shift gears now and talk a little bit about what the physicians and APPs should know about managing the cardiac medications around the time
Yeah.
of non-cardiac surgery. That's another, maybe we should have broke this into two talks. It's a lot of information, but I think
No,
it's
that's
well worth
fine.
discussing in this venue.
Yeah, so this gets complicated. I think there's a few simple ways to think about it. So, um, you look at each of the different medications. One of the medication type that if you break it down in terms of categories of medications, the medication category that I think has caused the three that cause the most angst are going to be beta blockers, are going to be antiplatelet therapy and anticoagulant therapy. Those have historically caused the most raised the most questions. And then lately, we have some more information about the SGLT2 inhibitors. So if we sort of break those down one at a time, um, beta blockers, there was a lot of excitement around the beta blockers back, in the late 90s or early 2000 because we had some of the decrease trials came out, which showed huge benefits to perioperative beta blockers. Those were Polderman studies, and as we know, his studies were ultimately sort of debunked for falsification of data. And we also had other studies come out, like the POISE trial, which found that giving high dose beta blockers right before cardiac surgery can actually cause harm. And so it's pretty clear that you do not want to start high dose beta blockers before cardiac surgery. You can make the patient hypotensive. You can increase their risk of stroke. And the studies would show that you actually increase the risk of mortality. So that could kill people. If the patient has a reason to be on a beta blocker and they're not on a beta blocker, you have to give yourself time to start it to ensure that they tolerate it, usually 7 up to 14 days. You start low and you go slow. You don't just give them a huge dose of a beta blocker and send them off to the operation. Now, certainly if they're on a beta blocker chronically, you continue it so that they don't develop heart failure exacerbation or angina or rapid arrhythmia post-op, but you don't start high dose beta blockers beforehand. So that covers the beta blockers. The antiplatelets, This is an evolving question. When can I take the patient off of the patient who's had a recent PCI, when can I take them off of dual antiplatelet therapy in the setting of non-cardiac surgery? The American guidelines and the ESC guidelines differ slightly on this. The ESC guidelines, I think, take an approach that is more consistent with our practice here at Mayo. I think more consistent with what I feel very comfortable doing. Given that stents have gotten better, the risk of stent thrombosis is decreasing. We're seeing more and more studies come out that maybe mono antiplatelet therapy sooner, it may be better for patients in terms of reducing bleeding risk. So I think a reasonable approach to take is the first question you have to ask is, why did the patient have the PCI? Because an elective PCI is very different than a PCI in the setting of ACS. The ischemic risk is going to be lower in patients that had an elective PCI rather than a PCI in acute setting. So what the European guidelines say, and what I think is reasonable, is if they had an elective PCI after 30 days of dual antiplatelet therapy, you can stop the clopidogrel, continue the aspirin, send them to the non-cardiac surgery, and then resume their clopidogrel afterwards. After 6 months, that's a class 1 recommendation. 30 days is a 2A, but I think 30 days, if you're in a pinch, is perfectly appropriate. If they've had a PCI for ACS, you have to give them at least 3 months of dual antiplatelet therapy. After 3 months, you could hold the clopidogrel as a 2B indication. After 6 months as a 2A indication, understanding that they need to resume it afterwards to complete 12 months of total therapy. Now, the American guidelines take a little bit of a different tact. They will say that after an ACS, they actually give a class 1 recommendation, waiting 12 months. Now, if the patient is having a really elective operation, I think that's probably fine. But if there's some time urgency to it, I think you could certainly get away with 6 months, potentially even 3 months. If they've had the American guidelines will say that if you've had a PCI in the elective setting, you should probably wait at least 3 months, whereas the European guidelines give you the out at 30 days. So there is some variation there. I think the European guidelines are probably more consistent with our practice, and that's the approach that I take. So we talked about the beta blockers, mentioned the antiplatelets, anticoagulation, right? What do I do with the patient's oral anticoagulant? Now, if they're on warfarin for valve disease, for a prosthetic valve, that's a whole different conversation. We could spend all day on it. I think the question comes up, what do you do if they're on AFib, if they have AFib or some other reason to be on warfarin? Because with the DOACs, it's relatively straightforward. The half-life is so short that you generally don't need to bridge, because the half-life is not really different from low molecular weight heparin. Now, you have to factor in the dose and the bleeding risk of the operation and the patient's renal function to determine when you discontinue it, and a number of app-based calculators are available to help with that. But if the patient is on warfarin, and the questions have come up with whether or not I need to cover this patient with heparin while their INR is subtherapeutic before I send them to the operation, and then post-operatively while their INR becomes therapeutic. And the data, number of trials, whether it's the BRIDGE trial or the PERIOP 2 trial, have really found that there's not a lot of benefit to pre or post-op bridging unless the patient is really, really high risk. So what are the guidelines define as high risk? If they've had a recent stroke, defined as the last 3 months, recent stroke or TIA in the last 3 months in the setting of AFib, then you can bridge them. But unless they've had a recent stroke, they probably don't need bridging for AFib. Now, if they have an active LV thrombus, if they have venous thromboembolic disease with a high risk of recurrence, like antiphospholipid antibody syndrome or protein C, protein S deficiency, those situations could certainly merit bridging in specific situations. The guidelines are differ on how we should handle so if a patient has AFib and they haven't had a recent stroke, what if they have a really high CHA2DS2-VASc score anyway? Maybe they had a stroke 12 months ago. Some of the guidelines in terms of will say that if they've had a CHA2DS2-VASc over 7, you could consider bridging. Others don't. Okay. So and this is going to differ between the ESC guidelines, ACC/AHA guidelines, and actually the ACP guidelines. But I think the bottom line is maybe that CHA2DS2-VASc over 7, definitely if they've had a stroke in the last 3 months, and then you've got to consider some of these other reasons that a patient might be on warfarin.
I always think the anticoagulation one's probably one of the hardest ones.
Mhm.
And you did a really nice job of helping us to understand that in general, for most prosthetic valves, you're not going to bridge them.
Well, it depends on the situation. The prosthetic valve question is a separate
Yeah.
entity. If they have a low risk aortic valve prosthesis, they generally don't need bridging, like a bileaflet mechanical prosthesis in the setting of normal LV function, no atrial fibrillation, no prior thromboembolic events. They generally don't need bridging. But if they have a mechanical mitral prosthesis, or they have LV dysfunction with a mechanical prosthesis, or they have a fib with a mechanical prosthesis, or they've clotted a mechanical prosthesis in the past, then you're going to need to bridge them.
Thank you for clarifying that. I appreciate that. Yeah, the one that we haven't touched on, and it's getting very popular, is the SGLT2 inhibitor.
Yeah. So SGLT2 inhibitors, obviously we use them a lot. They're part of the recommendations for heart failure therapy now. The data is actually pretty clear, and both the European and the American guidelines have come out and said that you need to hold SGLT2 inhibitors 3 or 4 days before non-cardiac surgery. Why? Because SGLT2 inhibitors have been shown to intensify the ketosis associated with perioperative fasting. And patients, regardless of whether or not they're diabetic, can actually develop this euglycemic ketoacidosis, where their bicarb goes down, they get this anion gap metabolic acidosis. They have their ketones go up in the serum and the urine. We're used to seeing this in the setting of DKA, but their glucose may be perfectly fine. And they have sort of non-specific symptoms. Maybe they're sort of little abdominal discomfort. Maybe they've got some diarrhea or nausea, but it's not like a patient saying my elephant's sitting on the chest like they might be if they're having an infarct. So the symptoms are non-specific, so you have to be on the lookout for this. And if the patient has not had the opportunity to hold their SGLT2 inhibitor before non-cardiac surgery, and they've been fasting, they're going to be at risk for this. So the guidelines say that you need to hold the SGLT2 inhibitor 3 or 4 days. That's a class 1 recommendation. All of the other heart failure therapy you want to continue. So ARNIs, ACE inhibitors, angiotensin receptor blockers, mineralocorticoid antagonists, beta blockers we talked about earlier. You continue those throughout the perioperative period because stopping them can increase the risk of heart failure exacerbation. But the SGLT2 inhibitors, you need to be careful about holding those ahead of time.
Even regardless whether they're diabetic or non-diabetic.
Correct.
Okay. Well, we covered a lot of really important topics in what was, a short amount of time, but I think you did a really nice job of simplifying some of these topics for us so we can refer back to them. Are there any other things that you'd like to highlight for our audience?
I think this can be confusing, particularly when you think about all of the testing. The way I like to approach these patients is when you see the patient, just take the operation out of the question, first of all, and just say, does this patient have anything that I need to do anything about, independent of whether or not do I need to get an echo? Do I need to get a natriuretic peptide? Is this patient, someone who I would stress whether or not they're having a cardiac surgery? Do I just need to cath them? And approach the management like that. Determine what you need to do, and then factor in the operation. That is probably the most prudent way to approach these patients, because if you don't need to do testing independent of the non-cardiac surgery, you probably don't need to do testing for the non-cardiac surgery. And then the medications, the big ones to know: antiplatelet therapy, SGLT2 inhibitors, warfarin. Those are sort of the big ones that can raise a lot of questions. I think we talked about those.
Well, this has been really, I learned a few new things myself. I really appreciate you bringing us up to date on the newest guidelines and highlighting along the way those things that the ESC guidelines might differ from the American guidelines. And maybe we'll have to think about bringing you back just to specifically talk about prosthetic valves, because that is
Sure.
always an area that
Yep.
gets a lot of time and energy in the clinic. So thank you very much for your expertise, and thank you to our audience for joining us on Interviews with the Expert.
At Mayo Clinic, relentless learning fuels world-class care. I'm Dr. Rajiv Gulati, Chair of the Division of Interventional Cardiology. If today's episode gave you a fresh insight, imagine what a full course can do for your patients. Head to cveducation.mayo.edu and explore our live and online programs, our quick on-demand modules, and our CME accredited masterclasses created and taught by the very voices you trust here. Join thousands of clinicians who've already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.